Virginia Conversations on Virginia Public Radio is underwritten by the Virginia Education Association, the men and women working in Virginia's public schools. VEA, teaching, learning, leading. Online at veanea.org.
Is there a doctor in the house? On today's edition of Virginia Conversations, the answer is yes. Two, in fact, and they're here to talk about the looming shortage of family physicians. I'm Ailey Lee. Thanks for joining us. You might call it a perfect storm. Older doctors are retiring, new ones opting more and more to go into specialized fields, and the aging baby boom generation will be in need of more care. On top of all that, the new Affordable Care Act, Obamacare, is bringing millions of new insured patients into the waiting room. So what's the solution? How do we get more family physicians into the mix? And can we expect proper health care if the shortage continues? To help answer those questions and yours, we welcome two family doctors who are educators as well. From our Charlottesville studio is Dr. Sean Reed, director of the Generalist Scholars Program and assistant professor of family medicine at the UVA School of Medicine. He's president-elect of the Virginia Academy of Family Physicians. At the studios of WVTF in Roanoke is Dr. Michael Jeremiah, Chair of Family and Community Medicine at Carilion Clinic and Associate Professor at Virginia Tech Carilion School of Medicine. Welcome to you both.
Good morning.
Good morning. I'm going to start with you, Dr. Jeremiah. Right now we have about 15,000 fewer doctors than we need, and that's estimated to grow to as much as 63,000 by 2015. What does a physician shortage look like? Does it mean less patient time? Does it mean the receptionist says, sorry, honey, we're not taking new patients? Does it mean quality suffers?
I think it can mean several of those. One aspect is going to be that patients may have a harder time getting into an office to either establish as a new patient or to get an appointment with their current physician, because if there are shortages, that means it's harder to recruit for any replacements, as you mentioned, retirements. So those same physicians that are in the group are now covering more hours, more patients, and means it's a little bit harder to get that access. So there may be delays in care, there's inconvenience, and then they may be seeking care at other sites, urgent cares, emergency rooms, where it's higher cost care and not necessarily taking into account the preventative and chronic disease management that they may need.
And what about your crystal ball, Dr. Reed?
Sure. I think part of the issue is not just the number of physicians, but the distribution of physicians. So there's been a number of studies that have looked at geographic mapping, and what we find is that most providers, physicians and other providers, are clustered around both urban centers and academic health centers. And so encouraging our provider force, the current workforce, to redistribute to rural communities, both here in Virginia and elsewhere, is going to be an important process of, as Dr. Jeremiah says, maintaining that access, because I think access is probably driving the most concern among our citizens.
We're seeing a proliferation of new forms of providers as well. We discussed, for instance, Walmart offering physicians to the client base.
We are, and there's a lot of unknowns that we're seeing coming across different systems in different states. Virginia, it's been a little bit slower in terms of some of those new trends, and I think we need to really look and see what they're bringing, what are the advantages, and what are some of the challenges. One of the things that we found in our system in Carilion is that we have a mix already of both physicians as well as other types of providers. We have physician assistants and nurse practitioners. Right now in our department, we have about 150 family physicians and general internal medicine physicians that are part of our department. And we have 50 nurse practitioners and physician assistants who are also part of those practices and work in a team-based fashion. That tends to work very well, and we're working on defining what are the skill sets and how can they really bring the strengths of any provider based on their training. In these other settings, in retail clinics and other commercial outlets, it's less clear to me.
Is it a spin-off of Patient First, doc-in-the-box type services?
I think that's part of it. I think there are some spin-offs in terms of convenience. There is a drive for having care available whenever, a patient may need that care. And we've seen an influx of urgent care coming to this part of the Commonwealth. And I don't think that's necessarily something that should be either encouraged or discouraged, but we need to look at it a little more closely and say, what's it really bringing? If it's convenient care, is it being comprehensive enough to really serve those needs and really improve health? And if it is, then that's a helpful part to access. But if it's not, then that may not be the right model.
Is that a segment of the population that is a valid a need? Maybe people who go to a Walmart physician know that they might not get the same things they would in a full-service facility, but that's a compromise they're willing to make.
Right, and I think that's the point to really key in on. And as Mike says, continuity of care and this cohesiveness of care, I think, is what's important. So as we bring on, and you're exactly right, we have the landscape for where you can receive health care in the United States is changing, most recently with the Walgreens pharmacy chain announcing that they plan to hire physicians and run clinics, insurance companies themselves, retail stores, et cetera. And the real issue is, how do we coordinate them into the traditional care model that was already in place? Because there are some concerns, I think, and as long as consumers and patients are eyes wide open to the limitations of that, I think, as Mike says, it should be neither discouraged nor encouraged. But fragmentation is an issue. And for instance, when you think about it in the individual patient, where a 15-year-old girl comes into one of these retail clinics for a well visit, or for sports physical for a volleyball team that she plans on playing in high school, seems like on the surface a pretty straightforward visit, one that could easily be managed by any number of very well-trained providers. But the challenge is that this is the only time, essentially, this age group comes into the clinic. And that's my window. That's my window to discuss with her appropriate health issues like tobacco, substance abuse, intimate partner violence, depression, other mental health issues, body image, you name it, menstrual irregularities, emotional, physical, responsible sexual practices, contraception. And it's my longitudinal relationship with that patient that allows me, if you will, and the trust that we've built up, to have permission to ask those questions. And I'm somewhat concerned that if we move to a model that doesn't allow for those types of discussions to happen at those moments, that we've lost something in the care of our adolescents particularly.
And I remember that you and I addressed this earlier this week, that relationship between the patient and the doctor is so key. And there's a chance of that eroding as more and more of these forms of health care are provided.
I think that's exactly right. And it doesn't have to. I just think there has to be, unfortunately, medicine does not have a wonderful track record of sharing information across health systems and across partners on that team. The Veterans Administration is perhaps the shimmering example of one that does. Whether you're in El Paso or here in Charlottesville, as a veteran, you have the same medical record, and that's wonderfully empowering. But if you go to a retail clinic where they have no access, those providers, unfortunately, are shooting in the dark. They don't know the psychosocial history of that patient or the past medical history, and that can be both unnerving to the patient but also potentially dangerous. And I think we really need to focus on integration to bring new partners, whomever they may be, into the fold so we can safely and efficiently share information about patients.
Let's also talk about another challenge, even for the established physician, the idea of cross-cultural communication. So a patient comes in who's very used to Eastern medicines and Eastern ways of healing, and now talking with a Western doctor, and perhaps add to that a language barrier. Now you have even more challenges to communication. I know that you've dealt with that directly, Dr. Reed.
I have. Charlottesville, as you may know, is an area that is purposefully and systematically and I think thoughtfully a community that integrates refugees into our population. And about 15 years ago, Dr. Fern Houck in my department realized with some others in the community that they needed special attention. As you say, many refugees coming from different parts of the world have different constructs. I deal with a population, I treat a population of Liberians who, to the best of my knowledge, really don't have a chronic disease model, at least the patients I'm working with. And so that poses challenges in their care. And we have 50 languages coming through our International Family Medicine Clinic here in Charlottesville, and that has resulted in our building systems and processes and policies in place to help nurture and support that very special population here.
Sean, I'd agree with you. We have a population that has immigrated to our surrounding areas as well, and it really does take some experience in that area to deliver the type of, I think, comprehensive care that will bring the benefits that the population is looking for. We use the language line and are able to have that ability to make sure that the instructions are clear and that you're getting the full history that you need to understand, what the issues are in the context of that patient's family as well as their culture that they're bringing.
We were talking about go ahead, Dr. Reed.
Well, I was just going to say, and as an example of how our partnership really works, the International Rescue Committee is a organization here in town that, Dr. Houck and our providers and our clinic has really formed partnerships and ways to communicate that effectively allow for that sharing of information so that we understand what's happening in the patient's lives outside the office, and that's so critical to us.
We're talking about that future landscape. What about right here in Virginia if Medicaid expansion occurs? Let's talk about some numbers.
Well, I think it is something that's on our minds, certainly in terms of meeting the current demand is challenging enough. And I know I'm sure it's similar for Sean, but for our system, we're looking at those practices that we're trying to recruit for retiring physicians. We're trying to meet the needs of our current patient population. But if we expand through the exchanges and through Medicaid expansion in the Commonwealth, we're looking at an expansion of up to 400,000 additional individuals who currently do not have insurance and may then have insurance and be seeking care in a way that they were not seeking it before. They may have been putting off visits to the physician or in getting their medications because they just couldn't afford it. So if they have that access, there's the potential to be able to help them to address longstanding needs that have not been addressed, but do we have the access? And I think that's the real crux.
Dr. Reed?
I think that's right. I mean, I think what we learned from the discussion this past summer in our legislative session was that the message is that many Virginians depend on Medicaid, and that the future is clear that more and more will depend on that service or that form of reimbursement for service. And so the other thing I think we learned, there's some agreement on, is that Medicaid is not optimally structured at this moment to provide the type of high-quality, efficient care that we need. And I think we can have that discussion too, but I think that's part of where the solution comes, is to build a robust Medicaid system and other parts of healthcare delivery, but particularly within that model, so that we can serve the new folks that are coming on with ACA.
There's an interesting article in The Foundry which quoted a Virginia physician. Now, he's an independent practice. His name is Dr. John Curry of Fairfax. I want to read you from a letter he wrote to one of his patients, who happened to be a columnist. Nevertheless, here's what it said, in basically explaining that he wants to go ahead and retire now. He's in his 70s, and thanks to influences including Obamacare, he feels like the exit sign is right there in front of him. He says, I'm in my mid-70s and have both the capacity and willingness to care for patients for another decade. But I'm retiring. I cannot stand it anymore. More than half of my time in the office is spent filling out forms, writing letters, responding to inquiries, and attending to urgent matters that did not exist 10 years ago. And every year, my income is less. At this point, I would rather be paid nothing and have the freedom to decide what is right for my patients. Dr. Jeremiah, does this ring a bell with you?
It's something that we're hearing with increasing frequency from our colleagues, that, meeting those demands of practice to just practice safe and effective medicine are being challenged by a lot of the barriers. And the barriers are, as this physician was mentioning, income, and seeing that there's disparities between what primary care physicians are paid compared to their colleagues, and trying to keep up with the overhead, and for new grads with the debt that they're saddled with coming out of their residencies. I think the other issues, though, that are very important that he mentions are the barriers day to day that are in the office, and that includes that paperwork aspect, the documentation requirements we have, the different forms that are required by insurance for pre-authorization of medications and so forth. Really make it a challenge to keep up and do the work of directly interacting with patients. And I think that's something that we're going to have to figure out to be able to keep people in medicine for longer periods of time, and they don't take that out of saying, I'm retiring before I really need to.
What do you think, Dr. Reed?
Well, I think, as Mike says, this is a message that we're hearing from the practicing family physicians across the Commonwealth. I mean, through the Virginia Academy of Family Physicians, we received that message, and we worked with partners in other parts of health system to implement a new committee. So one of the main focuses of our academy from a legislative standpoint is to actively work to reduce the administrative time that physicians spend each day, because that frees them up to provide the actual patient care that patients are counting on. And so there is a new Medicaid physician MCO, or Managed Care Organization Liaison Committee, that will have stakeholders from both insurance and from providers to really work through and remove some of the administrative burdens. And they'll look at things like prior authorizations. You know, that physician that you quoted in private practice has to hire an inordinate amount of support staff to try to wade through a very complex process, and in some instances has to ask permission. And I think, to be fair, I think that's appropriate in terms of prior authorization for certain procedures and imaging, et cetera. But I think it can be simpler, and I think so through this committee we really hope, and through that dialogue, we hope to really reduce those burdens so that we get less letters like that.
Good morning, Barbara from Damascus.
Hello.
Hi.
How are you today?
Just great.
Thanks for having me on. I had a two-part question, and I'll go ahead and ask it and let the doctors comment. My first concern is that hearing that retail outlets like Walmart might offer certain medical services, as well as tying that in with the fact that they will not have a complete history like the type that would be in major healthcare systems, where you can actually see what's going on with a patient, that they might go in for cheaper health care and not have all of that information available to the medical personnel there. Isn't that really a huge health risk for the population? Also that, I mean, just to be blunt about it, the doctors that are going to be working in Walmart aren't going to be the same kind of doctors that are working in a hospital with higher salaries, higher qualifications, and individuals who are specialized at things.
Mm-hmm. And what's your part two?
Part two is I'd like to hear a comment on the state that they see of healthcare in the United States based on nutrition. And I would like them to comment on the Hippocrates part of the Hippocratic Oath that says, let thy food be thy medicine, and thy medicine be thy food. And it seems like that's hugely missing in our healthcare system, especially in the cafeterias and hospitals.
Okay.
And I'd just like to hear their opinion on that.
Thank you so much, Barbara. What we'll do, because we're going to move into break, is, Dr. Jeremiah, why don't you address in these next couple of minutes the first question about Walmart? I know we did talk a little bit more, but she wants to flesh that out, and then we'll continue after the break with both of you.
Okay, sounds great. You know, I think your concerns are some of the same ones that we share. It's really an unknown, because this was announced by Walmart as one of the larger retailers about getting into that business of providing not only urgent care, but also looking at trying to provide what they're calling primary care or more chronic disease management. And we have no idea exactly how that model is going to work. I share Dr. Reed's concerns about the fragmentation that provides. And I think without having connections to an ongoing relationship and a record, then you're always going to be reinventing the history, and you have more chances of medication interaction problems, missing pieces of the history, and I worry about that. Obviously, the model of trying to expand access and that intention may be a good one, but there are other factors there. I think having a physician office within a retail clinic where you have the pharmacy and you have other shopping is something that they're interested in.
You're listening to Virginia Conversations. Next week, financial abuse of the elderly on the next Virginia Conversations. Stay with us, and we'll be back in 1 minute. Today, we're talking about the shortage of primary care physicians and how the Affordable Care Act might impact that situation. Our guests are Dr. Michael Jeremiah, Chair of Family and Community Medicine at Carilion Clinic, and Dr. Sean Reed, Director of the Generalist Scholars Program and Assistant Professor of Family Medicine at the UVA School of Medicine. Barbara from Damascus, and let's continue, Sean, with her comment about Walmart and these variables and these unknowns. Do you have more to add?
Well, I think she's right. I mean, I think in terms of the workforce and who Walmart decides to hire, I guess I would like to think that, the issue is not the quality of who they hire, but whether we handcuff them with the inability to really access their skill set. And as Mike said in his response, I think that ability, and as Barbara mentioned, to see that past medical history allows physicians and other providers to really to perform the skills that they're able to and they're trained to do. And without that, with that fragmentation of the record and the fragmentation of the personal relationship, because what you will say to a provider on a first encounter, in my experience, is very different than what my patients say to me on my 4th or 5th or 25th encounter.
And
I think,
go ahead.
Yeah, go ahead. Well, I was going to comment on her second question.
Yes. Go ahead,
Sure.
because she's talking about something very valid, nutrition. Let's see if we can prevent people from having to go into the doctor's office in the first place.
Sure. I think her question is right on point. There is no disagreement that the largest health issue in front of us is obesity. And I think there are many, from the White House down to the town hall, that folks are thinking long and hard about how to address this issue. Obesity puts patients at risk for a host of other chronic diseases. And she mentioned the cafeteria, and our health system realized that hypocrisy, or cued on that hypocrisy she was talking about, and basically implemented a stoplight program, which is red, green, and yellow, and it basically puts on food items on the menu displayed for everybody the ability to see red meaning high calorie and green meaning low calorie, and obviously yellow being in between, so consumers of food can make better decisions and educate themselves in our own cafeteria and raise awareness about that. And our department is working with our community. Our faculty are partnering with our residents and the Parks and Recreation Department here in Charlottesville, and we're trying to get youth moving. We're trying to get them to understand the value of an active lifestyle to try to address obesity, because the numbers, even in our community here, are abysmal, and we're trying to turn that around.
I would just add 2 things to what Sean said. I think it is such a great question, Barbara, because I think this is analogous to what we've had to battle in terms of smoking. We finally have gotten to the point where our hospitals now, most of them are smoke-free. And yet that question you had about hospital cafeterias is very poignant. And we have some similar efforts to what Dr. Reed is mentioning about, looking at healthy choices within a cafeteria. But the other thing that I want to just mention is we've got to train physicians, primary care physicians in particular, how to address these problems that lead to effective help for patients who really want to make those changes. Just telling them to eat less and exercise more isn't going to work. You got to get well past the advice and understand what are the barriers that people have to make lasting change, and work with them in terms of what previous success they've had and empowering them to do something different.
We know that there are 2 drivers to the perfect storm we addressed. Number 1 is this growing, aging population. Number 2, the supply of doctors. So the key word there is supply. My question is a 2-parter around that new pool of new doctors, trainees, and getting them into the market. Number 1 is, how do you graduate more medical school students? And number 2, how do you drive them toward general practice and not as much toward the subspecialties like dermatology, ophthalmology, which is where the trend is in more and more subspecialties versus general practice. Which of you'd like to take maybe part 1, graduating more medical students?
I'd be glad to start. I think that we're seeing the trend in graduating more physicians, and that's been through a growth of a number of different schools. We've seen a slow start to increase in the number of what they call allopathic schools for MDs, and a larger growth in osteopathic schools who are graduating physicians with that DO after their name. And combined, we're seeing an uptick in the number of total graduates. However, that doesn't necessarily translate into those that are then finishing residency, and particularly that challenge of trying to get them to choose a primary care residency choice.
Okay. Dr. Reed.
I think that, our residency programs here in Virginia, we do graduate 75 family physicians a year, and it's important to understand the multiplier effect of that. So each one of those providers, about half of which who will continue to practice in Virginia after graduation, will see between 1,500 and 2,500 patients on a panel. So I think we have a steady pipeline, but this issue of how do we continue to encourage individuals to both go into family medicine or other primary care fields, but also to practice locally is an important one. And we host national or statewide conferences called Choose Virginia, where our residents, our students, our faculty from around the Commonwealth come together to show students, particularly and residents, what life is like in Virginia and what practicing medicine can be like in Virginia. So we've tried to create some programs to help nurture those decisions.
There's just a couple other barriers there I think are worth mentioning. One is there is the disparity between the income that you can make as a primary care physician and those of their subspecialty colleagues. And because of the debt that has continued to climb from going through the medical school education process, then that drives a lot of the choice. That there's a similarity in hours that are worked between primary care and subspecialties, but if you have that disparity in what they can make salary-wise, then that's going to be a national attractor for choice for those students. So unless we address aspects of loan repayment or those salaries that the individuals can make in the specialties, I think we're going to continue to see challenges in trying to get enough of the graduates going into primary care to meet the coming needs.
Here's a legislative angle. The residency program to train doctors has, for decades, largely been financed by Medicare. Back in the 1990s, when Medicare costs were going up, Congress put a cap on that funding. And that exists today. So there are all lawmakers who are trying to say, look, it costs $145,000 to train a doctor. Let's remove that cap. Let's make it easier to graduate a doctor. Your thoughts?
I think following up on what Mike said, it's absolutely essential to recognize that you have to change the forces, the workforce changes. You have to change the incentives before you can start talking about providing new opportunities. One of the misnomers was adding new residency slots would actually help our workforce issue. And what we saw was that at the time that was being considered legislatively nationally, there were empty spots going by every year. And so the realization was that we need to somehow change the dynamic so that if we create more slots, that they will be filled. They will be filled by energetic new physicians that are interested in serving in primary care. And part of that, as Mike touched on, was the change and disparity between remuneration, but also just to help showcase primary care. It's interesting. I think in my job here at the university, I work with a number of students through all 4 years. And one of the most challenging things that I have is to show them, to model continuity of care or longitudinal care. The way we traditionally train medical students does not allow them to have that repetition of experience with patients, and that's changing. We are currently exploring ways for patients to be matched with students. So students will, for instance, get 4 or 5 patients that they follow over a 4-year period, that they become their medical mentor, and they stay with that patient for that time. And that will allow, I think, successfully patients and students to understand what it's like to practice primary care, and I think that will turn some lights on for some folks that perhaps have not had that experience.
We invite you to join our conversation. The toll-free number is 866-611-NEWS. That's 866-611-6397. It's not often you get 2 doctors in the same, quote, room. And we have them for a whole hour. Joan from Charlottesville, good morning to you. Joan, I understand you're...
I don't remember your name. But anyway, I'm an old retired RN. I started when there were 3-year programs, and we really got to work with doctors in the hospital. That's gone, and that's bad. That shouldn't have gone. I think nurses aren't working with doctors as much as they used to, and with the patient. I think they're working with papers. I see that today. Nurses were doctors' second hands and did a lot of work with doctors. That's going away. Another thing, I think doctors are settling in big areas, like there are an awful lot of doctors in Charlottesville. I rarely have to wait for an appointment here. And I think they're not dispersing into the smaller rural areas. I think that's another problem, because we lived all over this country, and I can see the difference. We have fantastic doctors here in this town, but I think we have tons of them, really. When you look at the yellow pages, that's great. But I think they're not going into the rural areas as much as they should. That could be a problem.
Thank you so much, Joan, for your call. Dr. Jeremiah?
Joan, those are great issues. I think the first part of what you said about nurses getting stuck with the same type of barriers that physicians are experiencing with the paperwork is a critical factor. And we are really trying to look at ways to do this concept called working to license, so that you have front office staff, nursing, and physicians working together to say, what are the skill sets that you're bringing, and are we doing the type of work that you really are trained to do? And nurses are trained in education and patient interaction physicians and really helping us to design that workflow. The other part that you mentioned about rural areas is another challenging issue too, and I can just tell you what we're doing in Carilion, and maybe Sean can mention about his experience. But it's tough to recruit and get people to move to those smaller towns and stay there. There are some loan repayment programs that help to initially get some physicians in those smaller communities, but keeping them there is very challenging. And we're offering different aspects of recruiting packages as well as compensation and support to larger areas that may be able to have connections to specialists or to their colleagues that seem to be helping us to recruit more effectively, but it's an ongoing challenge.
You know, it reminds me of something we talked about, Dr. Jeremiah. It's not directly related, but the role of nurse practitioners, the role of physician's assistants is going to be ever increasingly important. And tell me about the makeup of your workforce.
Well, as I mentioned earlier, we have about a quarter of our workforce, 50 of our 200 that are currently nurse practitioners and physician assistants in our primary care sites. And I expect that that's going to increase because we're having an increased number of graduates from those programs. Locally, we have some new ones that have started up. And the I guess promising aspect of that is not only trying to figure out how they can work together as in a team fashion, but to Joan's question, that we find nurse practitioners or physician assistants who grew up in some of those smaller towns, we sometimes have a much easier time recruiting them to be in those areas. Now, the challenge is to have partnerships with physicians, again, in those areas to make sure they have the backup and the collaboration that we want to see to really make it work best.
I know, Dr. Reed, team-based care is a big push for you.
Absolutely. A lot of great points made by Mike and Joan. I think team-based care is something that our clinics are really focused on at this point. We have redesigned and retooled the way that we work. We're working with our medical assistants. We're working with our RNs, our LPNs, our front desk staff, and our providers, including nurse practitioners. And it's really about trying to empower that team to take care of the needs of that patient and to understand and explain to the patient that that entire team has special services, as Mike mentioned. I think there's also this idea that training in communities where we grew up, the issue of GME funding for residency slots. Currently, to train in the United States, that means going to a major academic health center. There are other teaching centers that are being explored this past year where we're looking at if you train a physician or a nurse practitioner or, as Mike says, a nurse in an area where they grew up in, they are much, much more likely statistically to continue to return to that community or stay in that community and serve that local population. So I think those are all wonderful opportunities to try to disperse our workforce. And the state legislature actually 2 years ago helped, with our input, pass some legislation that made some scholarships and loan forgiveness available to not just physicians but other healthcare providers that are willing to serve in rural communities. And I think that's an important part of the process.
We have Ashley from Newport News as well as David from Virginia Beach in queue. And David, before we get to you, I know that you have a concern about the long wait for healthcare. If you don't mind, there'll be just a short wait for the radio program, so hang with us if we have to come to you after our break. But let me say hello first to Ashley. Good morning to you.
Hello, good morning. Calling from Newport News. I'm actually a Medicaid claim processor, a former Medicaid eligibility worker of Florida. And actually, oddly enough, too, I worked for HCA, the hospital responsible for the largest Medicaid fraud. And now their CEO is the governor of Florida, oddly enough. But I'm calling in also that a lot of people, every time I talk about like Vermont's single payer program that's going to go live 2016, nobody has a knowledge of it. And
can you give us a little background?
Well, all right. So when I talk to people about the differences of Medicaid, you have to remember Medicaid is one of those touchy subjects. A lot of people have a preconception idea of what Medicaid is and whom they serve. I mean, not only do they serve pregnant women and children, but also our senior citizens, because Medicare itself has a very large copay. So when we talk about, like, whether it be even as simple as our Food Drug Administration, about how, like, let's for example, like BPA products are legal in the United States, but illegal in Europe, China. And I explain to them because we are not invested in our healthcare system. Like, for example, England's invested and France is invested in their healthcare system. They're also, in Canada as well, they're going to be more invested in, like, for example, their food programs, the type of healthcare services they do provide. And one of the things that, for example, I guess Vermont's going with is the fact that if we invest not only in our people it's going to go better. It's going to be a much better cost savings in the long run. So 2016 is when we're going to see that what you call single payer system, and a lot of people don't understand or don't equate as well that Massachusetts has a public option.
Mm-hmm. And again, bottom line being that a single payer health care system is one in which the government, rather than private insurers, pay for the health care costs.
No, but that's a misnomer as well. We do in our own way. We actually go forward and then we pay the taxes. But one people don't think about, like, I always try to say, if you think it's the government really paying, it's you. Even right now, and I hate to put Walmart out there, but it's the easiest example. When you go to Walmart and you go fill out like a job application, the kiosk, they ask you, are you a veteran? Are you on public assistance? Are you over 65? Why are they doing that? It's kind of like it's a 2-for-1 for the Walmart system. They're cherry picking. They're getting people that already have a health care system. So I, as a veteran, already have health coverage through the VA. I'm not going to ask to buy from them. I, as a 65-year-old person, already have Medicare. I'm not going to use their insurance as a primary. I, as a person who already have public assistance, I'm already getting from the government health care, so I'm not going to also apply for Walmart. But that's just one example of many companies that use that, of ways cherry-picking their employees in a way. And I know probably some people are going to be upset about it, but it's actually a very big, you talk to any of the workers there at least, they agree. They're like, yeah, that's kind of how they do it.
And we'll probably tackle this after the break, but what would you like Sean and Mike to tackle here?
Oh, basically the single-payer system. Like, I know in Vermont, again,
okay.
they were grouping up the doctors, and they wanted it. They were fighting for it. It finally passed. I think during the time the Obamacare was having this big stink, and everyone was saying how horrible it was. Nobody once mentioned at that same time Vermont passed that single payer. So I want to know their point of view, what they think about that single payer system. And again, you do have that option to add more insurance privately, so therefore you do have a choice.
Great.
So go on.
That's what we'll do. Let's do that after the break. And your question is most appreciated, especially your viewpoint from the insurance end of things. So thank you very much. We'll tackle that right after the break. You're listening to Virginia Conversations on Virginia Public Radio. Find out more about upcoming topics and comment on past ones on Facebook. Search for Virginia Conversations and like us on Facebook. We're back in about 90 seconds.
Virginia Conversations on Virginia Public Radio is underwritten by the Virginia Education Association, supporting public discourse through sponsorship of Virginia Public Radio. Resources for parents and teachers online at veanea.org. More information about Virginia Conversations and other Virginia Public Radio programming can be found online at virginiapublicradio.org. This is Virginia Public Radio.
Today we're discussing the shortage of general practitioners and what can be done to remedy the need for those doctors. I'm May Lily Lee. Our guests are Dr. Sean Reed, Director of the Generalist Scholars Program and Assistant Professor of Family Medicine at the University of Virginia School of Medicine, and Dr. Michael Jeremiah, Chair of Family and Community Medicine at Carilion Clinic. Ashley from Newport News called. She works in the healthcare insurance business and had a question about single-payer systems. And I know that you have some input on that, Mike.
Ashley, I think it's a good question, and it really brings up a couple of different aspects. I'll comment on one or two. The aspect of a single payer system or global coverage, as you mentioned about Vermont or Massachusetts, is a fascinating one, and they've been perhaps more on the front line of trying to move in that particular direction. I think in the Commonwealth here, we're really looking at whether we're going to be expanding coverage through the exchanges as well as through Medicaid expansion. The first step in that was just approved, and that's a pilot that we were going to be able to do for what they call dual eligibles, and those are the individuals who have Medicare but then do have an income level that would also qualify them for Medicaid. And we're going to be able to have some pilots and innovations to see if we can better care for that population and keep them well enough to stay out of the hospital and ED setting whenever possible. But this idea of payment reform is a really important one, and I do think that relates to our supply of physicians and our ability to attract them in certain specialties. We have been paid under what is called the fee-for-service method, so that the more often you're seen by a physician, or the more tests that they run, or the more admissions that you have to an emergency room or a hospital, the more that those systems or hospitals or physicians are paid. So you're really paid when you're sick rather than to help keep you well. We're starting to see a movement in the other direction, and this is part of that effort to try to control costs and improve health. And so this payment reform is moving from what they call volume to value, and we're seeing some good initial steps in that direction. For the quality of care we provide, for keeping people out of the emergency room, keeping them out of the hospital, is starting to be built into some of the contracts with insurance companies, including with Medicaid. With Medicaid, they now have a certain amount that is per member per month that is trying to fund some of these new efforts. And one of them that I'll mention is called the medical home. That's a model that is being used by many primary care offices to help to not only treat your acute, your chronic, and your preventive services, but try to fill some of those what they call gaps in care. So if you're hospitalized and then leaving the hospital and then need to follow up with your physician, a care coordinator, that's a nursing position, is often a new position that's part of this medical home model, is calling you within the first 24 to 48 hours and saying, do you have your discharge instructions? Do you have access to your medications? Can you afford them? Can you get to your appointment? Do you have an appointment? And do you have transportation? And if you can address some of those barriers, we're seeing that readmission rates to the hospital within that first 30 days of when you left are going down. And that's a promising move in the right direction.
Sean.
Mike, you touched on some incredibly important issues there. Payment reform is again key to understanding how to maintain access. So one term for what Mike was describing is asynchronous care. So the patient that's at home that was recently started on a statin for their high cholesterol that needs titration of that medication, the only model in place currently from an insurance standpoint is to bring that patient back into my office and discuss that. There are other ways. My patients currently have the ability to send me electronic communication through the electronic medical record, and a member of my team, a nurse practitioner, for instance, could easily manage that chronic disease and preserve access for the more difficult or challenging or acutely ill patient in the office space. So I really would like to underscore that I hope that we'll continue to see some healthcare reform. And Mike touched on this just briefly on some of the data, but adding one family physician per 1,000 people in a community decreases the hospitalization of pneumonia, heart attack, and heart failure by 7%, 5%, and 8%. And while those numbers may not seem staggering to some of the viewers, that hospitalization is the crux or the bulk of the cost of healthcare in the United States. And so those are hundreds of millions and billions of dollars nationally. And so I think, again, getting a workforce in place and having that payment reform is an important part of access.
David was from Virginia Beach, and he had called in concerned about the long wait for health care. And I apologize, David, if we made you wait too long. But that's a valid concern when we're looking at shortages of available doctors.
I think it is, and this is tying to something that Sean just said. In terms of improving access, we've discussed some aspects of trying to make sure there are enough graduates from medical schools and then getting into residency programs and then choosing primary care as a specialty. And I'll mention two aspects. One is that when we talk about primary care, just want to make sure that we are defining it in the same way. Primary care usually involves family medicine, internal medicine, and pediatrics, kind of across that age span and gender. But for our pediatric and internal medicine colleagues, often they will start into a program that is more broad and general, and then we're seeing that they will then later choose a subspecialty. And there's a lot, as we mentioned, a lot of pressures from a financial and other aspects to drive that. The other part about access I'll just comment on is right where Sean was mentioning about the what we call a patient portal, and this is through the electronic record where you can be able to answer a question or give advice without even coming into the office, and that does expand access. And whether it's done by the phone or through an electronic medical record, both can be an important part of expanding the ability to interact and get good healthcare advice. But currently there is not payment for that type of service. Now, there is in other states, and I think there are some efforts that are starting to happen in the Commonwealth, but we really need to expand those and make that happen so we can have, more real-time access and preserve the office visits for those that really need them.
Mike, you mentioned medical schools. James from Charlottesville has a comment along those lines. Good morning, James.
Good morning.
What is your comment or question?
My comment was that there has seemed to have been in medical education in this country for years a resistance to increasing medical student enrollment. It's like UVA went from 130 in the mid-130s in 1972 to like the mid-140s in 2013. There's a great resistance there to increasing enrollment, and so this plays into this. Why has that been the case? Why haven't our medical schools been more flexible to admitting the students that we need in the first place?
Thanks, James. Sean, do you want to take that?
Sure. You're right, James. We have steadily and perhaps somewhat cautiously increased our class size, and I think that has to do with trying to preserve the quality of education that we provide, and also just recognizing the incredible resources that it does take to train a physician over a 4-year, and then if you consider residency, 7 to 10-year period. Our current enrollment is a little greater than 160, and I think it ties into this idea that we have to think about, where will they go after medical school? So the number of GME spots has been capped. That's the graduate medical education, and we have to think about realistically, do we have enough residency slots in primary care and other specialties that will allow these aspiring physicians to find appropriate training and to matriculate into the workforce and start providing care? And I think there's a balance there, and whether we're exactly on point there or not, I guess is up for some discussion. But I feel like the students that leave us are appropriately finding their niche in the House of Medicine and are thriving.
We have a call from Yorktown. Good morning, Sherry.
I'm a retired registered dietitian who moved here from Massachusetts about 8 years ago, and I am absolutely amazed how underutilized the dietitians are here. And I had a referral service for about 75 referring physicians on Cape Cod, and had a lot of support and what have you, knowing only too well that there are deficits in nutrition, education, recipe adjustments, barriers such as ethnicity, financial, underlying issues, which are the primary reasons for overeating. So the psychology and physiology have to be addressed. But it's amazing when one of your doctors talks about team-based care and value that rarely in conversations here do physicians talk about dietitians or refer patients or clients to dietitians for such things as diabetic basic information.
Thank you so much for that comment, Sherry.
Sherry, I think it's a great point, and it gets to this point of team-based care and really making that happen. I think the utilization of nutrition in our education for our physicians is one component of that, so that they're aware enough of how important that is, and some of their colleagues who have specialized training like yourself. How do we make that work? This concept of the medical home that I mentioned has been broadened in some discussions to call it the medical neighborhood, and that's involving beyond just the physician and the nurse practitioner and physician assistants and the members who are immediately part of that staff in one office, to include registered dietitians, to be able to include pharmacists, social workers, psychologists, and really trying to look at what are the needs of the population that they're serving and how do you integrate those services. We actually have in one of our teaching sites, we have a pharmacist who has a certain number of hours there. We have a registered dietitian who's there counseling patients. We're working on getting a social worker. But one of the challenges, particularly for registered dietitians, is not all insurance companies will reimburse for those consultation services. And that becomes a barrier. So how do we start working on the contracting to help them to realize the importance of that service is one thing that we're working on right now.
And from Hampton, we have a call from Margaret. Good morning.
Hello. I'm a retired psychiatrist and an acupuncturist presently, And my opinion is that our current medical system is overly reliant on medication. We're missing a huge component of preventive care by not utilizing certain services. In the past, osteopaths used to do adjustments. Now they don't. Chiropractic can be very helpful for chronic pain, as can acupuncture for chronic pain and a variety of ailments. And unfortunately, the focus now seems to be, well, get on your medication. All medications have significant side effects, and sometimes they're very well indicated, and other times they're just overused. And I wish people would look at true preventive medicine, and I'm not talking about diagnostic interventions. Thank you.
Thank you, and that certainly is another way to help with the shortage of doctors, is to seek other forms of treatment. Would you, Sean, like to comment on that?
Sure. I think she's correct that I think on occasion we are too apt to reach for the tools that we're most comfortable with, and as we've been talking about building this team, we have new resources, new skill sets, new individuals, and in my department we have recreated our management systems for chronic pain patients. And so that now includes a much more comprehensive assessment of their mental health, and including a referral to one of our behavioral health specialists who sees them and assesses them for how they are perceiving their pain. And also one of our new providers just recently completed, interestingly, Margaret, an acupunctural program that allows her to use that modality to help treat chronic pain. Things like exercise and even nutrition and wellness and other avenues allows patients to experience pain differently. And I think you're correct, so it may seem easier to reach for that prescription pad or the electronic medical record, but utilizing some of these other skills that you've mentioned on our team is really important to us, particularly in the care of our chronic pain patients.
Just one comment to add. First of all, Margaret, I think the combination of psychiatry and acupuncture is a fascinating one. So kudos to you for pursuing both fields. I think the other challenge for us is any alternative or allied, health service, making sure that it's actually going to produce the outcomes that we're seeking. And I do think for acupuncture, there are some good studies that show that benefit. And so we also are looking at ways to utilize that particular service. There's other ones that are less clear, and I think we just have to really look and see, anything that has potential benefit, studying and making sure if it does indeed produce a benefit, how do we incorporate that into our offerings.
Another call in from Stanton. Good morning, Joe.
Good morning. Interesting conversation. About 20 years ago, HIPAA was introduced to the medical community, and even the lay population now knows of HIPAA. Can your guest address why we have instituted the restrictions of HIPAA, but we haven't created the portability of health information? Your guests have mentioned electronic medical records and transfer of that health information record. But with HIPAA, that was the premise of that, is to allow information of one's medical records to be transferred all across the country. Thanks a lot.
Thanks, Joe. We'll take that offline. Sean?
I think HIPAA has implemented an important safeguard in medicine, and that is obviously the protection of very personal information. As you point out, Joe, it's actually had an interesting consequence, which is, in some regards, almost a barrier to providing patient care, in the sense that if one of my patients is seen in an outside facility, there has to be this exchange of a written paper with a signature and a fax and at the very least a phone call and some computer work to get access to that information. I think in terms of portability, it really cuts to the core of our structure of our economy, and that is, competition. And as you have different health systems, if you look at an analogy of gaming systems for children and for adults, a lot of those gaming systems don't interact from a computer standpoint. Same thing in healthcare. It's very challenging for the health system that I work in to communicate with the private company across town. And I think I know our state government and our national government are working on that. There are grants here in Virginia to create a black box, if you will, that will allow different proprietary health system records or electronic health records to import their information into this quote-unquote black box and then export it out in a shape and fashion. The trick is to get it into the same shape that that physician or clinician is used to looking at. And I think that portability, when we're able to cross that technology barrier, I think will be very, very helpful.
And that is all the time we have for this edition of Virginia Conversations. That hour went by quickly. I want to thank our guests, Dr. Michael Jeremiah from Carilion Clinic and Dr. Sean Reed from the UVA School of Medicine. I appreciate that they took time today to talk with us. And thanks to you for listening and calling and joining in today's conversation. Next Friday at 9, a growing problem for older folks, financial abuse. And it's not just strangers taking advantage of the elderly. We'll hear from the experts on how it's happening and how you can help your loved ones to avoid this next Friday on Virginia Conversations. Until then, I'm May Lily Lee. Have a great week.
Virginia Conversations on Virginia Public Radio is underwritten by the Virginia Education Association, the men and women working in Virginia's public schools. VEA, Teaching, Learning, Leading. Online at veanea.org. And by listeners of this Virginia Public Radio member station. Listeners can hear this program again or access other Virginia Public Radio news content at virginiapublicradio.org. This is Virginia Public Radio.